So next is epigastric stab wound. It's a V15. A 22-year-old man arrives in the ED with single stab wound in his epigastrium. His heart rate is 100 beats per minute and his blood pressure is 105/80. What injuries should you have sustained? So it's epigastrium, it's junction of the thorax and abdomen. So we should talk about the thorax first. So it's tension pneumothorax, massive hemothorax, cardiac tamponade, and great vessel injury. And in the abdomen, liver laceration, splenic injury, all viscous perforation like stomach, small bowel, and colon, retroperitoneal organs, pancreas, and kidney, and the great vessels, and mesenteric laceration. And how will you assess the patient? Obviously, he has trauma, so we will follow the ATLAS protocols, and during the primary survey, we will identify and resuscitate at the same time, especially the pneumothorax, hemothorax, cardiac tamponade, intra-abdominal hemorrhage, and the peritonitis. Obtain the chest X-ray for pneumothorax, hemothorax, mediastinal widening, and pneumoperitoneum and pneumomediastinum. Perform a fast scan for intra-abdominal free fluid and pericardial views to look for pericardial fluid. The chest X-ray demonstrates pneumoperitoneum while the first scan shows some free fluid in the Morrison's pouch. What are you going to do? So he is tachycardic with free gas and fluid in the abdomen. He has perforated hollow organ and is leaking bowel content into the peritoneum. Also risk of bleeding. He needs a laparotomy, and CT scan may not give you any more helpful information and delays time to hemostasis and contaminate. Mention noted. What are the general principles of trauma laparotomy? So WHO checklist: give antibiotic, ask for to place an NG tube, decompress patient, warmer on, prep and drape from torso so that tracheotomy or other extended excisions can be made if required in the space laterally for placement of temporary abdominal dressing in the event of laparotomy formation. Use a full length midline incision from xiphi to pubis, pubic symphysis pubis. Have 2 wide bore suckers and 10 large abdominal packs. First priority is to make the abdominal cavity sequentially and then pack the abdominal cavity sequentially and then locate first any source of bleeding and then sources of contamination and to control them. You find approximately 2 liters of blood in his abdomen. No source is immediately appeared. How will you proceed? So we eviscerate the small bowel up towards the patient right quadrant to permit optimal packing. 4-quadrant packing. Then assessment of the uninjured quadrant first, ending with the removing packs from the most likely injured region. Right upper quadrant area bleeding from the liver, IVC, lesser omentum, duodenum. Left upper quadrant, so right upper quadrant bleeding from liver, IVC, lesser omentum, duodenum, pancreas, right adrenal, right kidney, and retrohepatic IVC. Left upper quadrant bleeding from the spleen, left lobe of liver, stomach, diaphragm, pancreas, left adrenal, and left kidney. Assessment of the infracoelic compartments by lifting the omentum and transverse colon out of the abdomen, moving small bowel laterally, packing to the left and right of the small bowel, mesentery bleeding from the bowel, mesentery and peritoneum, small bowel lifted out and pelvis packed, bleeding from fractures, pelvic vessels or organs. Describe the methods of mobilizing the abdominal viscera. So cauterization of the duodenum, which can come toward the white outfront rod in the ascending colon cecum, that's called cattle brush maneuver. And similarly, if you're worried about the left kidney and then you have to move the left viscera to the right, this is called Matox maneuver. And at laparotomy, there is only minimal free intraperitoneal blood but a large retroperitoneal hematoma in the midline. Describe the zones of the retroperitoneum and how this guides the management of the penetrating wounds. So retroperitoneum is divided into 3 zones. Zone marks from the diaphragm superiorly to the deviation of the aorta and laterally from the hilum of the both kidneys. And zone 2 includes from hilum towards the kidney, and zone 3 extends from the thoracic aortic bifurcation down into the pelvis and includes the iliac artery and veins. All zone 1 penetrating injuries need to be explored, and supramesocholic injuries require supraciliac aortic control, and inframesenteric require infrarenal aorta IVC control. Zone 1 injuries should be explored in the penetrating trauma, particularly if there is evidence of bleeding, ischemic hematoma, or cardiovascular instability. These zones can be closely observed in blunt trauma, and if the patient has not undergone a pre-operative CT scan, this can be undertaken postoperatively. Particular injuries to the kidneys can be treated conservatively and it is important to provide the kidney or confirm on pre or post-op scan.